The next topic we're going to be talking about is IVF add-ons and what you really need as part of your surrogacy journey. There's certainly IVF clinics are now offering a vast array of add-ons such as pre-genetic testing, scratch tests, embryo glue and regular IVF. What do we really need and how is it actually going to work? I'll just give you a quick overview on our two speakers today. Dr. Sandy Chuan is a dedicated fertility specialist, double board certified in obstetrics and gynecology and reproductive medicine. Sandy embarked on her medical career as an undergraduate at University of California, where she received a Bachelor of Science in Biological Science and a Bachelor of Arts in Comparative Literature. How exciting. Sandy obtained her medical degree from the prestigious University of California, Los Angeles School of Medicine. And our other speaker, Dr. Michael Kettle, who has visited Australia before, graduated with honours from the University of Arizona and now works in San Diego Fertility Centre. Michael likes to help couples start their families, and it's one of the greatest privileges and pleasures that he actually has, and he looks forward to sharing that knowledge with our conference attendees today. So please extend a warm welcome to Sandy and Michael.
Thank you, Karen. Also like to thank the conference for inviting Dr. Chuan and myself to participate. We've been here before and love to come to Sydney. It's a wonderful place and it's gorgeous. Watching the lights of Vivid last night on the over the Opera House is just truly stunning. I'm going to just basically introduce the topic today, give you a little background information about us, and then turn over the bulk of this morning's presentation to Dr. Chuan. So these are the physicians that practice with me in San Diego. There's 5 of us. Dr. Chuan and I are here today, but Dr. Park, Dr. Friedman, and Dr. Donishman join us as well. They've also traveled to Australia, so you may have heard reputations about them along the way as well. And this is our beautiful center. It's in Del Mar. For those of you who are familiar with the San Diego area, Del Mar is a beautiful coastal community. My office is on the 2nd floor, and you can actually see the ocean from there. So it's a nice place to spend your days. So the basics of IVF have already been discussed by Dr. Hesla, and he did a wonderful job presenting the science of IVF. And what we're going to do is expand on that a little bit this morning and talk about some of the extras that are available to you. And this is where you can really begin to individualize your journey, where it becomes important to have a special relationship with your physician, where your physician knows your individual story quite closely and then can recommend various different adjuvants that might help you reach that pregnancy success that we're all about. Part of that may be just simply identifying an egg donor. And egg donors can come from lots of different sources and in lots of different ways. In different centers, they provide you with different pieces of information about the egg donor process. In our particular in-house program, you see pictures and profiles and you get to learn a lot about those individual young women. You're allowed different sorts of relationships with the donors through us. They can be completely anonymous. You will know a lot more about them than they will about you for certain. You can have what we call a semi-known relationship, and you can have a completely known relationship. And we offer those different options to you. Clearly, there has to be a mutual agreement to that between the intended parents and the donor, but you'd be surprised how many donors, in essence, really want to get to know you a little bit as well. Same thing for surrogacy, and Adrian did, again, a wonderful job with the basics of surrogacy. Surrogacy is much different than egg donation because in surrogacy you will certainly get to know your surrogate and you will ultimately have a very intimate relationship with that person as she starts that journey towards parenthood with you. Focusing again on what we're going to do today, Dr. Chuan's going to go through several different important things. Some of them have been touched upon, like genetic testing, and she'll give you some more details about that, both the pros and the cons, and then some other things that are somewhat controversial, whether they have solid scientific background or not, whether they should be universally applied to everyone or not. And she'll go through those things so that you can begin to formulate some great questions for when you're having your consultation with your individual physician to plan for your specific treatment plan. So with that said, Dr. Chuan can take over from here.
Good morning, everybody. Thank you, Michael. So this is the part where I'm going to say, I hope you had your coffee. I will do my best to try to teach you about some of the more complicated things, the add-ons of IVF, so that you can have an understanding of how to individualize your care. I think that when it comes to egg donation, I think that takes a little bit of some of these things out of that equation. But for those of you who are thinking about using your own eggs, it's important to know how some of these things can really be impactful. So I'm going to skip over these because this is just kind of the overview of the IVF process. But really, I think as Dr. Hessla mentioned, that there's, obviously getting the eggs, transferring the embryos that are created, and then selecting the embryo to be transferred. So these are the focus of what I'm going to be talking about today. So ovarian stimulation is important for, many reasons. I think thinking about how many eggs we can get certainly can make an impact on your final outcome. And then how do we improve the quality of the eggs that we get? So, what we know is that the woman is born with one set of eggs. We never get more of them. It's very unfair biology, but it is what it is. The men create new sperm every 2 months, but for the women, we're born with one set, and from birth, it just declines. And along with that, because these are the oldest cells in the body, the quality of them go down as well. And so just thinking about energy-wise, it's like putting a battery in a flashlight and not using it for a long time. That can decline with time. And then certainly the eggs become more fragile so that you can end up with more and more abnormalities in the chromosome number. And that's why PGS, which has been talked about, becomes an important part of IVF as well. But there is very intricate crosstalk in the cells when the egg is developing. So the egg is surrounded actually by special cells, granulosa cells, theca cells, which are important for the development of the egg, and the egg really also crosstalks back and impacts the development of those cells. And so understanding the physiology of that becomes important to how we think about how to change that dynamic. We can't change the fact that we're aging, we can't change the battery pack out, but what can we do to try to improve the development of the eggs as we're stimulating the growth? So this is a really simple schematic that shows you in the center, the little blue dot, that's the egg, and around it all the cells that start to grow as the egg is developing. And basically what we know is that in that process, androgens, so male hormones, are actually produced in the ovary, and that can be important for the development of what's called FSH receptors, so follicle stimulating hormone receptors, and that determines your response to FSH. So when we do ovarian stimulation, what we're doing is your body normally only produces enough for one egg to develop per month, and you actually send up, maybe when you're young, maybe there's 15 or 20 of them. As we get older, that number declines, but regardless, your body only utilizes one out of that group. And so when we do IVF, we give you extra FSH hormone to hope that if these follicle stimulating hormone receptors are there and responsive, that those eggs will start to develop. Now, the idea is, though, I can have someone who has 2 different people that have 10 follicles, but they don't always respond the same way when I give the same dose of medication. And that's where the individual egg quality comes in. And so the idea is that, because male hormone is produced within the ovary, and that becomes important naturally to the FSH response, if we supplement you with these androgens, could that make a difference and help improve your follicular response, meaning improve the number of eggs that can ultimately develop? There's some small studies that focus on this. this, it's really, really difficult to do large randomized control trials in IVF. And I think just partly because it's a smaller number of patients, it's also everybody's situation is different, your body's dynamic every month. But there have been some small series studies showing that if you supplement the women before they go through ovarian stimulation with testosterone, that it could improve the number of eggs that we can get. And so I think because there's not a lot of downside in doing this, really it's just a matter of whether or not the patient can have access to testosterone. I think in the US, our patients can get that very easily, so you will often find physicians will have this as an adjunct for patients who are poor, anticipated to be poor responders. The other thing is adding a DHEA supplementation, which is just something you can get over the counter. DHEA is a type of hormone, male hormone, again, that's produced in the ovary and by your adrenal glands. And so that's something that we will often put patients on before they come through. So 75 to about 100 milligrams a month or two before. You could take it long term. There's no harm in doing that. So I do think that these are adjuncts that you will find that many of the physicians in the US are incorporating. Growth hormone, there is a growth hormone story. The idea is that growth hormone could theoretically improve the quality of the granulosa cells, because as we get older, granulosa cells may not proliferate as well, which can lead to, obviously, issues with estrogen levels not increasing appropriately in the cycle, poor response. So there have been a lot of studies, hundreds in the US, looking at growth hormone in different capacities. And there were 3 big meta-analyses that really showed that there could be some benefit, maybe 3 to 4-fold increase in some of the studies in terms of increasing pregnancy rate. But it is still controversial because the cost of growth hormone, it's about $500 US for 2 doses. And so you will find that there are times when patients may not be able to afford that addition, but it is something that we will often at San Diego Fertility Center offer as an addition to your IVF cycle, to hope not to necessarily improve the number of eggs that we get, but it will potentially increase the quality of the eggs and how they function and how they will do in the embryo culturing process and becoming a blastocyst. The next part, we're going to talk about embryo transfer. Really, what can we do to improve the chance of the embryo implanting? There's basic things. Obviously, making sure you do evaluation that the uterus does not contain polyps or fibroids that can obstruct implantation. Sometimes for patients with repeat implantation failure, simply it's identifying a surrogate who has been pregnant before and has a normal uterine environment. But regardless, there are add-ons and things that we could think about to try to improve that process. And as the embryo develops, you see in the top picture that this is a really intricate process that happens in the fallopian tubes, and certainly in IVF it happens in the laboratory. But once you get to the transfer and you put the embryo in, there is a very significant crosstalk that happens between the embryo and the uterus to facilitate that implantation process, and it's kind of a mystery to all of us. And so it's really hard to identify particular cellular factors that you can change to make that process better, and we believe that the embryo itself actually produces a lot of growth factors that controls that. So that's why this process is predominantly, I think, controlled by embryo quality and not necessarily just whose uterus it is as well. But I want to talk to you today about embryo glue, endometrial scratch, and some of the new uterine evaluation assays that we've been starting to incorporate more in the US. So embryo glue is just really a supplementation. It's a hyaluronic acid supplementation that was introduced in culture media to try to improve implantation. It's actually a branded product. And the idea is that this is something, hyaluronic acid is something that is present in your fallopian tubes, in your uterus at the time of implantation, and that theoretically that forming this coating around the embryo will help improve the ability of that embryo to kind of be more sticky, quote unquote, in the embryo, in the uterine lining. So there have been some studies that show that in patients with recurrent IVF failures that this can improve the ability of that embryo to implant. But the problem is, again, we need randomized controlled trials. So this is something that is on protocol. at our center, and we do utilize it. But again, there's not been any harm demonstrated, so that's why we feel comfortable. But there still needs to be large studies that are done to be able to really truly validate whether or not this has a highest significant benefit as the producers of this product say. Endometrial scratch, you may have heard of. This is something that is fairly easy to do. It's a procedure where you put a tiny little catheter into the uterus and you basically disrupt the endometrium prior to the time of embryo transfer. And it could be done 7 days prior or up to a month prior. And the idea is by disrupting the lining that you're changing the inflammatory process within the lining, and so affecting this very complex process of implantation and inducing kind of a different lining from developing. And there have been some studies that show that in patients with unexplained infertility, as well as patients with repeat implantation failure, just that by adding this particular very simple kind of mechanical disruption, that you can improve implantation rates. And because this process is so complex and difficult, and we really, there's limitations to what we can understand to that level, that I don't know that anybody could tell you the specific mechanism why this works, but it is something that we have incorporated. Many centers will incorporate. There is a large study in about 900 patients that we're awaiting the results on to really try to shed some more light. But at this point, I think that there is not harm in doing this. So there's times when, many times when we are utilizing our patients, I would say that in the surrogate population, you're less likely going to find that we're using this. But we have, we occasionally have had, for whatever reason, surrogates that have gone through 1 or 2 transfers without success, and sometimes that will be incorporated as well for those surrogates. Yes. And endometrial receptivity assays are the new thing. So you may have heard of this. It's kind of all over the internet. 2 of these are endometrial receptivity assay and something called Receptiva. I'll just briefly go through these. So basically the idea is that in the endometrium, you have to expose the lining to a certain amount of days of progesterone for there to be the optimal implantation window. And that has to match up with the age of the embryo. So if you want to transfer a blastocyst, you need to have 5 to 6 days of progesterone. And the idea is that there are some patients who potentially may have a window that is off, meaning that they get the appropriate amount of progesterone, but their uterine lining still is not receptive to the embryo. So this assay for ERA basically is looking at the genes that are expressed at the time when the uterus is receptive, doing an analysis. And so what it requires is a biopsy. Same thing, you put a catheter into the uterus and you extract some of the sample, send it off for testing, and they'll give you a report that tells you, based on the amount of progesterone you got, if your uterus is pre-receptive, receptive, or post-receptive, meaning it's gotten too much progesterone. And based on that, you can adjust the timing of how long someone is going to receive progesterone. So having a personalized embryo transfer plan. And so there are some small studies that initially when they did the studies, what they found was that about 25% of the women who actually had repeat implantation failure did not have an appropriate receptive window. And so of those women, half of them became pregnant when they did this personalized transfer timing. They're still awaiting a large cohort study. This is something that we are talking to more and more of our patients about, and anecdotally, I think in our center we have seen some benefit for the patients. So wait for the story, but I do think that it can be appropriate to incorporate this if you're someone who has had repeat implantation failure. And then the Receptiva assay is looking at whether or not someone who doesn't have any symptoms of endometriosis may actually have chronic inflammation in their uterus that can increase the resistance to progesterone, which makes it harder for the embryo to implant. And so this assay is just doing that. It's looking for those markers. And if it comes back positive, there is treatment available to hopefully change the dynamic in the uterus and improve implantation. I think the studies have all come from one author, but I do, anecdotally in our center, I have seen a difference with my patients who have come in with repeat implantation failure or patients with recurrent pregnancy loss. Many of them have come back with positive assays and ultimately positive outcomes with the appropriate treatment. Want to touch upon embryo selection for transfer. I don't want to belabor the point because Dr. Hessler already gave you a really nice synopsis of PGS, but the idea is that PGS becomes an important add-on because prior to the event of PGS, we've only been able to look at embryos by just looking at the way they look, morphological grading, and it's like judging a book by its cover. It's not really a great way to identify the embryos that truly have the ability to implant. But we do know that having abnormal chromosome number is something that obstructs and prevents implantation. Having the right number of chromosomes is like having the right blueprint when you're building a house. And if you don't have the right blueprint, your house is not going to go appropriately. And so that's why that becomes such an important add-on to make sure that we are choosing the right embryo. All human beings must get 23 chromosomes from the egg and 23 from the sperm to make 46 chromosomes to have the appropriate blueprint. And on top of that, on these chromosomes are all of the genes that make us who we are, but can also, we can have mutations in these genes that leads to certain important diseases. So that's why the event of pre-implantation genetic testing has been so impactful in our field, because not only can we look at chromosome number, if you're someone who has a family history or a mutation predisposition, we can test for those as well. And so this is the new language. Basically, pre-implantation genetic testing now has multiple components. Testing for PGT-A is basically looking for chromosome number. So that's something that we could do on all the embryos just to make sure it has that 23 pairs, 46 chromosomes. The second piece of information that it can tell us is gender. And so for patients who are interested in family balancing, choosing having a boy or a girl, this technology has allowed us to be able to do that well for our patients, and it is legal in the US. If you're someone who has a translocation, PGT-SR, structural arrangements, it can identify that as well. That's pretty rare. It's common, though, in patients with recurrent pregnancy loss. And then PGT-M, which is looking for single gene defect. That would be like if you are a carrier for a disease called, let's say, cystic fibrosis. You're a carrier, your partner's a carrier. So together, you have 25% chance of having a child that has that disease. Well, they can go through a special process to create probes to identify that disease in your embryos to prevent the transfer of an embryo that actually has that disease. So that's pretty phenomenal. And again, that's done through a biopsy process where you take 4 to 6 cells from the embryo. The benefit Dr. Hessler already talked about, is that there's a lot of embryos that are created that are abnormal, and with age, that becomes a significant factor. But I think that when you look at this graph, you see that with the egg donors, there's actually a lot of chromosomally normal embryos. Even if you don't do the testing, I think that there's a very, very good chance that you can get and transfer an embryo that is normal. But as you get older, that probability becomes lower and lower. So even if you have embryos that make it to blast, you may, if you just don't do this test, if you don't do this testing, you're going to potentially be transferring embryos that are just abnormal and will not result in a healthy pregnancy. And so you see this, that in women who are older than 40, PGS has a huge impact on pregnancy rates. However, when you're looking at younger women, there's not been as huge of an impact in terms of increasing success rates, so pregnancy rates, and lowering miscarriage rates. And I think that's just because the probability of abnormal embryos is lower in the younger women. And so I think that, yes, there's lots of centers that are advocating PGS for everybody, including egg donors across the board, to try to pick that one best embryo. But when you look at the data, don't be surprised if you do come across some fertility specialists that are going to say to you, If you're using an egg donor, potentially, you may not need to do this test. It is a biopsy to the embryo. It's more cost. And, you know, the studies haven't shown as great of a benefit as it has in women who are older than 37. So I think you really need to consider that and talk to that about, you know, about that with your patients, about the risk and benefits, and making an informed decision on that. And PGS does have its limitations. You're taking 4 to 6 cells to try to interpret an embryo that has 120 to 150 cells, so there could be sampling errors as well. So it's 95% accurate, but certainly we don't quote 100. So important to individualize that choice with your physician. And again, this is a big study that has shown that egg donor cycles, we haven't seen as big of an impact as we thought that we would. So the key take-home message is that IVF treatment is really complex. There's lots of things that you can manipulate and try to adjust. Choosing the right stimulation protocol may change how many eggs you might get. And I think that's really an important part of what we focus on at our center, and I think at a lot of centers in the US. I think that the field is ever changing, and there's so much that we still don't understand because there's limitations. The biology of reproduction is really complex, happening inside your body, hard to study. And so we do have to be careful when we start incorporating things, but it's also, that's what makes this field exciting, is because you're constantly thinking of new ways to try to improve outcomes. And it really does take a long time, and sometimes patients do say, I feel like I'm a little bit of a guinea pig, and unfortunately in this field, because without trying the treatment, sometimes it's hard to decipher truly whether or not it has a huge impact. But I think our philosophy is always, first, do no harm. So when we look at the literature, we will always say, could it be harmful? If it can be, we're not going to try it. But if we think that this could have a benefit, we will talk to the patients about the risk and benefit to help them decide if they should do that. And so I think my personal philosophy, and I think the philosophy at our center, is that every single patient is unique. And it doesn't matter if you're using an egg donor or a surrogate, there's going to be unique circumstances that important to consider for you. And if you're using your own eggs, certainly that's absolutely the case. And our bodies are dynamic from month to month. And so really the key is to talk to your physicians, understand the process so that we can help individualize your care to bring about the best outcome for your treatment. Thank you.
That was absolutely fascinating, Dr. Chuan, and it's so heartening. I mean, I went through surrogacy 20 years ago, but just the medical breakthroughs that are happening now is really exciting. Now, we've just got a couple of minutes for questions. Now, where's our microphone person? Kaz has got the microphone.
This is for Sandy. Do you have any thoughts about using coenzyme Q10, prednisolone, and melatonin?
You know, those are common supplements that people ask about. Oh. I hope that I'm loud enough. Actually, you know, there is some data on coenzyme Q10 that it can be helpful. It's a really strong antioxidant, and so I don't think that there's any harm in taking that. And I actually will ask my patients, the couple, to both take it, because there is some data too that it can improve sperm quality. Because if you think about it, it's just about reducing oxidative stress, which is everywhere in our environment, which could damage our cells. So it's actually good for your heart, your lungs, and and your brain. So I think anything that's good for those parts of your body is going to be good for your eggs and your sperm. So I usually have my patients, you'll hear in the US 600 to 800 milligrams, but we'll do 800 milligrams daily. As far as melatonin, I think there is some data on that being helpful to egg quality. I think it's really hard to say, though, again, we need randomized controlled trials, and I don't think that there's anybody that's going to necessarily invest in that. But again, it helps with your sleep cycle. So I don't think there's any downside to taking melatonin. So even though I don't force my patients to say, you have to take this and this is going to make 100% difference in your cycle, I think that if they're open to taking it, I don't think that it could be harmful. And so typically when you come to our center, we'll give you this little list of, you know, supplements that people are often asking about. And, you know, that's one of the ones that are on there. Okay? Thank you.
Thank you. We might just make this the last question.
Hi, I just want to ask, after how many unsuccessful IVF cycles should a couple look into surrogacy? I know it could be individualised again, but what's the baseline? Because it's all too confusing, yeah.
That's absolutely a really, really valid question, but it is very individualized because I think it depends on why your IVF cycles were unsuccessful. So that's where when you speak to your physician, you need to provide them with the information about your past cycles. It's helpful to know the embryo quality because certainly, like I said, probably about 75–80% of success is directed by the embryo. So if your quality of your embryos were poor, then the problem may not be your uterus. And so in that case, it may not be reasonable to say that you need a surrogate. However, there are patients who have very clear uterine pathology, or they've used egg donor embryos and really good quality, and they're still having implantation failure. So then that proves that probably we may not be able to diagnose why, but that they would benefit from a surrogate. Now with the advent of some of these new assays, I do think there's some insights that we can glean from whether or not potentially they have undiagnosed endometriosis with these markers that are being expressed, or maybe their personal implantation window is off. So I don't think that that's the whole story, but I do think it's helpful in helping patients figure out when surrogacy may be appropriate for them. But I don't have a specific number of cycles, but I think if you used egg donor embryos and you've had 3 to 4 failed transfers and we've done all the testing and everything looks good and we can't figure out why, then that might be a very reasonable thing to consider using a surrogate. Sometimes I have patients that tell me, I've done many cycles, I have one precious embryo, and I've had all these failed cycles. Is it reasonable? I don't think it's unreasonable at that point because it's just hard to know going back in time whether or not it was potentially when they were younger, if their embryos were healthy, right, and they still didn't implant, what the cause was. So I think it absolutely has to be individualized. Okay.
That I think, that whole topic, I think is just a whole issue that we really need to start questioning. And often you hear in Australia of couples who have gone through sometimes 15 cycles. Anyway, moving along, I'd just like to thank Dr. Chuan and Dr. Kettle for their very interesting presentation this morning.